Okay, so welcome everyone. This is our October 2021 COVID update. And Dr. Saleeby and I have been working together now for about four and a half years. And he is my collaborating physician. And I'm so excited to summarize for you today a lot of what we've seen in the last 19 months in our respective clinics, as well as give you a good overview of what we learned at the ILADS conference 2 weeks ago in Florida, which is typically a Lyme disease conference. However, we really spent almost an entire day there out of 3 days talking about COVID. And we got to hear Dr. McCullough and Pierre Corey talk, and it was just really exciting to be there. I felt after a pretty discouraging time of trying to treat people for COVID and getting a lot of pushback from the conventional community. So I'm thrilled to be sharing a lot of this information with you. We're going to try to give you a good overview, and then you'll have the recording, so you can always go back and watch. If there's more detail you want to get into, you can pause and go back and watch. So Dr. Saleeby has been practicing medicine for 30 years now. He is a member of IFM, which is the Institute for Functional Medicine, as well as the Association for the Advancement of Restorative Medicine, which is AARM. He's also a member of ILADS. And he focuses on hormone balance, tick-borne pathogen illness, hypothyroid, dysbiosis, leaky gut, and autoimmune disorders, as do I. In 2018, he founded the Priority Health Academy, which is a nonprofit. And in this academy, we have an annual conference, which providers and health coaches and nurses are welcome to attend. And it's really dedicated to provider education training for healthcare providers, especially in functional medicine, and people interested in learning more about functional medicine. So, and I think most of you here know me. So with that, I'm going to share my slides and we will get started. Here we go. All right, and the first slide is you, Dr. Saleeby. Let's see if we can go ahead.
Okay, good deal. So some numbers, just want to share with the latest from Johns Hopkins, who kind of contribute to the world meter as far as some data. So as of today, it's close to 5 million dead from COVID worldwide due to, to the pandemic to date. Now, this is this a true figure? Because then we have to wonder, these numbers, most of these are deaths that are being tabulated from in-hospital deaths. So are these folks dying from the COVID virus itself, or are they dying because of the lack of good outpatient treatment and or inpatient treatment? Are we giving them the right sort of patient? So that has to all be filtered out. We have to kind of look at that data with better scrutiny to determine how many true dead from the virus and then sequela, or due to poor choices of drugs like remdesivir or something like that. So I'm going to kind of focus my part on the kind of the long COVID or the post-acute COVID. But it's kind of, we need to sort of define that. So acute COVID illness, somewhere between 2 and 6 weeks, they call it phase 1. And then long COVID or long haulers or post-COVID syndromes can be situations greater than 6 weeks out, phase 2. They can persist for over 3 weeks, and they can pop up not necessarily 1 or 2 days later. I mean, we had a patient recently who had COVID, 9 days was better, and then almost a year to the date of first getting infected, started to come down with long COVID or post-COVID syndrome. So it's all over the place. It's estimated between anywhere from 10 to 35% of cases, depending on what study you're looking at, of acute COVID will progress to long COVID. And this increases to about 85% of those who have been hospitalized, at least in one study, that go on to long COVID or post-COVID syndrome. And I'll talk about some of the other nomenclature and how they refer to it. And this may have to do with some of the, ACE2 receptors and something called TMPR5 554 that are involved in the pathology of this disease and how it affects cardiac, pulmonary, and things like that.
Wonderful. So yeah, so one thing that we talk about often, just to try to ease people's nerves, is how to protect ourselves from the virus. You know, a lot of us at this point have our kids back in school, back in daycare. And so this comes down to traditional functional medicine. And this is what we do at the Functional Medicine Center and at Dr. Saleeby's practice at Carolina Holistic is, you know, we're typically checking zinc, vitamin D. I include copper levels so I can look at the balance between zinc and copper. And this is because you cannot absorb zinc at the same time as you absorb copper. So they're opposing as they enter the cells. So we have a couple patients where we've discovered they're being exposed to copper and probably in their water source. And so it's actually been very helpful to find the source of the copper, and we can stop the copper coming in so that then we can actually give them higher doses of zinc. They absorb the zinc, and now their immune system is better prepared to be exposed to, quite frankly, any virus, but especially COVID. And then stress is huge. You know, I think for many people, COVID, the pandemic has been the straw that broke the camel's back because already they didn't have great self-care in place. You know, especially I think, you know, not to single people out, but especially our working moms, you know, they're trying to juggle 8 different balls and something has to drop, and they need more sleep. They need more downtime. They need time when they're allowed to have fun, you know? So one thing I tell people when they call me, if they do get COVID, the first day is especially like put on comedy, like watch something funny, do something where you're laughing or dancing or moving, but not strenuous, you know? Oftentimes having that to-do list and going to the gym is on the to-do list is just more stress. Exercise, that's why I ask people to try some movement and joyful movement as opposed to like pounding it at the gym, because that can also mess with our cortisol, which Dr. Saleeby is going to talk about later as well. And then, of course, underlying causes of inflammation. You know, we know that in this country, we have work to do on our food, on our diet. And it's not just the food we're eating, it's also the toxins that are in the food, even if we eat really healthy. There was an interesting presentation at the North Carolina Integrative Medical Society conference this summer, and one of the doctors, Dr. Friedman there, talked about glyphosates in our food and how it's really not the gluten that we're reacting to, it's the glyphosate. So it's a very interesting conversation. I have plenty more information where it comes to toxin exposure. If you want any more information, just let us know. And that should say dysbiosis and infection, not inflection, but underlying infections like Epstein-Barr virus, HHV6, Coxsackie, strep, usually in more of our pediatric patients. This can cause inflammation and you can flare. So you can have a chronic infection that will flare if you're exposed to COVID. So we want to do all the work up front to make sure that inflammation is at its lowest when you are exposed, so that your body has the best chance of clearing COVID without the large inflammation, inflammatory response, and the large release of cytokines that we're seeing. And then hormone imbalances. You know, something that's really, really essential, especially for our female patients, is that if estrogen is low or too high, it's going to drastically affect allergies and the immune system. And so we really need to look at especially all hormones, but estrogen, progesterone. Progesterone is like our anti-anxiety hormone. We need it. And a lot of women have low progesterone. So this is essential just to making sure you're at your best. And then I do recommend working with a coach on some of the lifestyle changes. And that's because when you see Dr. Saleeby or I for a visit, we're really focused on some of these complex medical things. And so to sit there and spend the whole visit talking about food or sleep may not be the best, you know, use of money or time. And so this is where having somebody like Kelly, or I know Dr. Saleeby has a list of coaches that he loves, but ask us if you want to see a coach because it can be hugely helpful. And working on underlying cardiac inflammation. So, you know, in my practice, and Dr. Saleeby can speak to this too, I'm seeing more people with underlying infections as well as toxins that are causing inflammation to the heart. I don't know if you agree with that, Dr. Saleeby.
Yeah, I just wanted, before we moved away from the slide, for sure, talk about the chronic smoldering, maybe occult infections. So we're seeing an uptick in, let's say, Lyme disease. I've made way more diagnoses of Lyme, not because people are out camping and getting tick bitten, but the fact that if they do get COVID, it activates or reactivates their Lyme, which may be sort of subclinical, not enough to get them to go to the doctor's office about it, but now we're facing all the full symptom list of what you see with a tick-borne infection. Not only Lyme, but I should say, but Babesia, Bartonella, those kind of things.
Yeah, your audio is cutting out a little bit, Dr. Saleeby. I don't know if you have headphones. Yeah, there you go. I think if you move closer, it works. But yeah, Babesia, Bartonella, and we can do the symptom questionnaire, like the Horowitz questionnaire or the MSQ, and then we can also order more advanced, sophisticated labs. But we don't test for tick-borne illness using LabCorp request because it's just not sensitive enough. So. And then zinc picolinate, in general, I use zinc picolinate, especially because of heavy metal exposure, and it helps to chelate and get rid of the heavy metals. I also use vitamin D3, and people come in with all sorts of different, they have vitamin D2, or they have this one from Whole Foods that I have not tested in a lab, but I'm suspicious it doesn't contain vitamin D like they say it does, because people will take it and it does not raise their vitamin D levels. Even people that I can get them on a different formulation of vitamin D, even if they have a receptor issue or a genetic issue with vitamin D, if we use a quality vitamin D, I do see it coming up. So be careful with buying things from CVS, Target. Definitely rely on things that we know are tested and quality supplements. And then this is where we really need to do some individualized medicine, because in order to prevent you from getting sick with COVID, we need to know how deficient you are to start with. And so, for example, if I've just met someone like 2 weeks ago and then they call me and they have COVID, if I have labs back, I can usually tailor the treatment, and I can tell them, you're someone that needs to take 50,000 units of D, whereas somebody else that has enough vitamin D, I may not bump it up that high. But certainly we know that the virus itself is going to deplete your vitamin D and going to deplete your zinc level. So
one thing on zinc, when Peter McCulley published his paper back in either November, December of 2020, his algorithm showed the zinc as zinc sulfate at 250 milligrams. That can be a little bit confusing because that's a huge dose if you use a different form. So I made the conversions for my patients to what I usually recommend, starting off for preventive at 30 to 60 milligrams of zinc. So that was a kind of a little bit of a source of confusion if you go back and look at that algorithm sheet. The other thing is the FLCCC, as I like to call them. They're not necessarily all functional medicine docs, so some of their recommendations as far as the nutraceuticals, I think, are a little skinny. We tend to get much more aggressive with them. I was a little bit dismayed that they took curcumin off. They kept the cumin seed extract there, but recently they updated it to exclude curcumin, at least in the preventive. So the other fault, I would say, because I'm a member of that alliance, and I got a chance to speak with Pierre at the conference briefly, and really admire what they have done. But I think one of the faults is they tend to update their protocols too frequently, and it can be a source of confusion for the patients monitoring and following that site, as well as some of the clinicians. What do you think, Kate?
Yeah, I agree. And everybody, we're talking about flcc.net. And I'll show you, actually, I have the link later in the slides. And so in my opinion, general information or general guidelines will never replace individualized medicine. And so if you have a provider that actually knows you and has done your blood work, that's the person to ask about what dose should I take, or do I need curcumin, or do I need resveratrol, or especially if they know your diet, where they know your stress level. I mean, all of this comes into play, especially when we're using nutraceuticals. For example, I have some picky eaters in the practice, and I know they're not getting B vitamins. Dr. Iris just asked about B vitamins, and I know they're not eating leafy greens because they have a tongue tie and they don't like the texture of leafy greens. So especially in those people, I'm obviously upping their Bs. And I think especially with cycling women, we up the B vitamins. But so my point is, nothing can really replace getting a sense of sitting with a provider who has experience, who can also see exactly what you need. So. All right, so if you can see in the chat, that's where I put the link. So I also wanted to mention a little talk about antibodies. You know, we don't recommend that you routinely test your nose for COVID. And there's a few reasons for this. One reason is that, you know, some of the test is picking up parts of the virus, not whole virus. You can be exposed and fight it off with little to no symptoms, especially if you've had the vaccine or the jab. And probably other people too, like my kids. You know, I can't imagine at this point that they haven't been exposed, but this is just an example of what an antibody test would look like. This is with LabCorp. Still, it is required to be covered by insurance. So if you want to know if you have antibodies, IgG, we can test with LabCorp. We also are testing a quantitative titer, which I'll show you next. And so we can see if you have antibodies, how high are they? It says abnormal because this person does have antibodies. In this case, this would be helpful. If they're exposed to COVID, it would be helpful to have antibodies. Oops, I'm sorry. And then the other thing was we can do T-cell testing. So we can do T-cell testing with a lab called InfectoLab. And I just sent the first one off with InfectoLab. It's $180. This lab, interestingly, is also testing T-cell response to Epstein-Barr virus. So I'm really excited to actually start testing that because antibodies are B cells and it's really only part of the immune system. The T-cell response to a virus is essential. And so I want to know if people are having a T-cell response, especially people that got the vaccine and weren't exposed. I want to know if they actually had a T-cell response. Okay, and then if you are exposed to COVID, what do you do? Well, the first thing I recommend is please call your provider early and don't wait, because there's this virus, we consider it the viral phase, basically day 1 to 5. People do in general pretty okay during day 1 to 5. It's after that that they start to decompensate and not feel, and feel really horrible. And that's not the virus, that's the inflammation and the cytokine response. And so it's really important to know what to have on board to prevent the inflammation from getting worse. And the worst thing is when somebody calls me and it's like day 9, and they're blue. That's not good. So I prefer to hear from people on day 2 to 3, and they've had a swab and they know it's positive. And then, I'm seeing a lot of people with low zinc. So in some patients, I am increasing the zinc to up to 300, but we may need to split the dose due to nausea. Everybody's getting 50 milligrams for sure, but it kind of depends on the person and what we tested. Vitamin D, I'm doing up to 50,000 on day 1. Josh was just here, our other PA, and he mentioned he's giving injections of vitamin D at his other practice. And he's finding that's really helpful on day 1 to give an injection of vitamin D. I think that especially helps if you have the VDL or the vitamin D receptor issue. Quercetin is just great for stabilizing mast cells, especially if you also have allergies. Quercetin is great. Some people do feel anxious with quercetin. And to me, these are my patients that either have a COMT or a CBS mutation or both. But be careful because some people cannot take quercetin. And this is why it's also helpful to have a provider that already knows you and has already done this testing. Lemon balm. Yeah,
Kate,
go ahead.
Kate, before we move away from quercetin, I've had on 2 occasions, I've had either nutritionists or health coaches, which are, working with some of my patients, advise my patients not to take the quercetin with the zinc because of what has popped up on a genomic panel. And my feelings counter that. I think it's very important that you take quercetin with the zinc concomitantly at the same time because it acts as an ionophore to help push the zinc into the cell where it's effective. It's not going to be effective circulating in the bloodstream. So I think, if you have to weigh this, maybe a little agitation or a theoretical problem may get in the way of saving a life. So I kind of err on the side of using this compound.
Yeah, and I think it's also a matter of, how anxious your patients are, and you can manage that, like telling them, well, this is going to go away in a couple of days as you lower the dose. Yeah, absolutely. And then in the very beginning, I started using lemon balm. The caution with lemon balm herb is you have to be careful with people with Hashimoto's and hypothyroidism, functional hypo. It does lower thyroid response. However, sometimes it also just convinces my patients to stay in bed and rest because they are more tired. So it's not that you can't use it with Hashimoto's, it's a short term. Helps with mood as well. And I got this from a lecture I had with an immunologist. She's a researcher, Dr. Heather Zawicki, and she published an article about it, which I'm sharing with you on the next slide. And then IV monoclonal antibodies. So we're doing this in the clinic. It's 10 milliliters and we're doing it IV. You can also just do an injection, but it would have to be about 3 injections to get that volume. And we're using this in people who are high risk. We received 20 doses from the state, and then we just received another 20. So now we've used about 5 doses. So we've got 35 doses left. It is definitely, to me, making a big difference, but it's not an immediate response. So it's taking 24 hours before we see the pulse ox come up and before we see the person's symptoms improve. It seems to be helping the most with the flu-like pain that people are getting in the beginning, the first 5 days. It is not recommended to use after day 7, and we can use it in high-risk patients as prophylaxis. Like, for example, I have a patient now and their son has COVID and the son is 12 and they're taking care of the son. So we're gonna give it prophylactically to the parent. But again, you're supposed to be high risk in order to qualify for it because we have to send paperwork in. And then ivermectin, Dr. Saleeby is gonna talk more about this, but we saw a lot of research on how it works. The trouble right now is getting it. And I've sent prescriptions to a couple of pharmacies in the last couple of days and gotten a lot of pushback. It sounds like there's a pharmacy in Texas and a pharmacy in New Jersey that will both mail it here. The FLCC website also has a way for patients to get ivermectin by scrolling through their list of pharmacies that will dispense it for COVID. But that list is not updated super often, and some of those pharmacies are no longer able to give it. So it's really kind of a pain in the butt, which is why we have so many other things we can try if we can't get ivermectin.
Right. I think ivermectin is, if you follow the FLCCC site and their weekly, they have a Wednesday evening webinar that starts at 7 p.m. Eastern Standard Time that is open to the public. And it's sometimes entertaining. Pierre and Dr. Merrick and a few others will get on and they'll talk about the topic. Sometimes they have attorneys on that'll help with people trying to get ivermectin to their family members in the hospital or from pharmacies that aren't dispensing. We tend to stay away from the retail pharmacies because they're very difficult to deal with, and you'll find it easier to deal with compounding pharmacies. The FLCCC website does have a list of prescribing physicians throughout the country, as well as pharmacies. And like Kate mentioned, they may not be updated as frequently as they should, but you can go and type in your state and you'll get a list. So I have one nurse on staff whose daily routine, or at least weekly routine, is to call typically the 4 pharmacies we use in the region that will ship to both North and South Carolina. And number 1, find out if they've got the ivermectin powder in stock to compound it. And if they are still, being able to fill on time. Some pharmacies, it's a 2-week to 4-week delay. And if you've got somebody with acute COVID, they need their ivermectin right away to turn them around. You can't wait 2 weeks. And I've gotten away from prescribing the 3 milligram tablets. It's too expensive. Prices have more than doubled in the last couple of months, and it's actually much more affordable. And you can control the prescription better by using the UPS pharmacopoeia powder that's available to the pharmacies, and have them compound your doses. It's all over the place. If you're using weight-based, anywhere from 0.2 to 0.6 milligrams per kilogram body weight. And it depends on the severity of the illness, as does the dosing schedule. We'll get into that in a minute, I guess. But I find that just prescribing 20 milligram caps and then dosing it either 40 milligrams for the first 5 to 10 days, and then bi-weekly at the lower dose, or depending on their body weight. If they're lightweight, you might want to use a lower dose, but if they're anywhere from 150 to 200 pounds, a 20 milligram capsule generally will get cranked out of a pharmacy much quicker than writing for 32 milligrams.
And Dr. Saleeby, I know you've seen over, when you checked your EMR, over 500 COVID, whether long or acute COVID cases. Has anyone that you saw had a side effects to ivermectin?
Yeah, so I data mined my EHR, and we had actually 503 COVID-related cases. Some of them were acute COVID, some were post-COVID syndromes, and the ones that I eliminated were the post-vaccine injuries and the ivermectin prophylaxis inquiries. So what I've seen is it's extremely well tolerated. Where I see a problem is we had a patient request liquid because they didn't like to, this was an adult patient, they didn't like to swallow a pill. So they requested liquid for herself and her adult son and husband, and all three of them had reactions to the liquid. It was sweetened with stevia. We don't know if they just didn't tolerate that, but they were sick, nausea and vomiting. I also had a suspicion that they had Lyme. The mother we know had Lyme, and I have a feeling the son and the husband may have also undiagnosed, and they could have been herxing. So the other outside of the liquid, which I'm not going to prescribe liquids really anymore because of this, but and it may have been the pharmacy, the way they prepared it. But I think the other minor reactions, and it's only been 2 or 3 other patients who've reported Herxheimer reactions after dosing the ivermectin, which makes me think they've had a huge bioload or something that's causing them to herx because of a big die-off. But by and large, even at the higher doses, and we've gone as high as 45 milligrams per day dosing, extremely well tolerated. Yep. Nobody had to go to poison control, by the way.
And thank you, Ludi. Ludi is a coach, but she brought her son in before they went to a trip overseas. And we did give him liquid ivermectin, and he did great. We did weight-based because he doesn't swallow pills. So thanks, Ludi, for volunteering that. And then inhaled budesonide. So at the beginning of this pandemic, we really hesitated to use steroids, but what we've seen is that steroids will help a lot with the inflammation. So I'm not giving steroids in the beginning of COVID, but if we get to day 6 or 7 and we're seeing pulse ox plummet, then that's what I'm usually starting with, inhaled budesonide, and then offering prednisone or oral steroids if needed. And we've had about 80, 85, somewhere in there, acute COVID patients with no hospitalization. So at this point, I certainly feel like I can say that without, and I think the bottom line is, as providers, we want to help, and we feel strongly that doing nothing is the worst thing to do, right? So, Dr. Pierre Corey did an interview that I'll send out at the end where he talked about working in the ICU and people saying just supportive care, just give Tylenol and fluids for COVID. And he feels like doing nothing is really malpractice for obvious reasons, So anyway, and we'll talk about the Tylenol in just a moment here. And I'm sorry about the text at the bottom. I don't know how it got there. I certainly didn't put it there. If somebody tried to type in the chat and put that, maybe see if you can delete it. But for some reason, we're seeing some weird text at the bottom. So this was just the interview with Dr. Heather Zawicki for this Natural Medicine magazine. She's an herbalist, and she owns a brand called Zamia Life, ZAMIA. But for years before that, she actually did research on vaccines, especially coronavirus vaccines. And when she got COVID herself in March of 2020, she actually just took large doses of lemon balm, like very large doses of lemon balm. And she also mentions, she lives in Washington, so she's allowed to say that cannabis also has the rosmarinic acid, which decreases the inflammation. So, she can talk about cannabis in Washington. And then here's the website. And actually, I missed a C, right? It's FL-CCC. Sorry.
Yeah, Kate, it's there's an extra C in there.
Oops. Let me see if I can just fix it real quick so we don't have confusion. There we go.
And I think in the chat section, it was also missing a C. But if you Google FLCCC, you'll get their websites.
Yep. And so
Yeah.
this is their step 1 treatment that is up on their website right now. Melatonin is also helpful. Obviously, it can cause drowsiness. And then the black cumin seed, I haven't used this yet. Have you used it, Dr. Saleeby?
Yeah, quite a bit actually. I was a little bit dismayed that they took curcumin off there because I use that quite a bit, like CuraPro or something like high dose, and I also pair it up with the Nigeria sativa, which actually Life Extent, not to promote any particular brand, but Life Extension Foundation or LF, they have a combination of curcumin and cumin seed extract that's really sweet because you only have that one bottle to open, and you do 500 milligrams BID. I just want to comment on some of the vitamin D levels here that again, these are not functional guys. Most of them are pulmonologists and intensivists, and but they're doing a great job. I was very happy to see they were utilizing and recommending equal measure of these nutraceuticals along with ivermectin. So we go 5,000 to 10,000, even 20,000 IU per day of D3, vitamin C 1,000, BID to TID depending on severity of illness, prophylactically maybe 1,000 a day, quercetin 250 daily to up to 500 BID, and then zinc, and then the melatonin. I would advise people use lower doses. Start with maybe 3 milligrams, and you can escalate up to maybe 10 or 9, since you can do in divisions of 3, 6, 9. You have to warn people about nightmares and things like that. Some people don't tolerate it. Never take it other than at bedtime. Don't take it in morning or afternoon. And they do have some sustained release versions of melatonin, or even this under sublingual sprays that are options as well. There are a couple others I'll add to this, like andrographis and wormwood can be used as an alternative to ivermectin if it's not available.
Yeah, when I got off the plane from the conference, I actually felt like I was coming down with something, and I took the artemisian. So this is just one case study, right? This is not a
N of one.
N of one, but I do think that the wormwood can be helpful, especially in our patients that already have dysbiosis. To me, it makes sense to focus on the gut because that's where the immune system is as well. So I'm going to go through a little bit faster so we can get through everything and we have time for Dr. Saleeby's slides. So this is also on the website. These are just screenshots that I took straight from the website. I do recommend that people have pulse oximeters at home just so they don't have to come to the clinic. We're not having people with symptoms come inside our clinic. We're doing telehealth, and then if we have to do an IV, we're doing it in the parking lot. So we can test people for COVID in their car. But I do like it if you have a pulse oximeter at home. You can get them on Amazon for $10. And then they talk a little bit here also about the iodine, the povidone iodine 1%. I have also had patients use the peroxide, which we're going to talk about in a moment. But yeah, and I've added fluvoxamine for patients with great results. And I have not used, I'm trying to think, I used finasteride once, but I haven't used the other anti-androgens often. Have you used the anti-androgens, Dr. Saleeby?
Yeah, they were really pushing hard on this. There was studies coming out of Brazil with Dr. Fabio, and he kind of came up with this, and there's been some studies and papers on it. I'm a little leery. I won't use it in female patients, even though they said it's fine to use in the females as well as males. But I found that when I used spironolactone and any of the other anti-androgens, it wasn't very well tolerated. So I have actually stopped using it. I will only use it in severe cases. Fluvoxamine, Luvox, again, they're recommending even up to 100 milligrams a day, which is very aggressive, not very well tolerated. It's an SSRI. So I always query my patients about their previous use of SSRIs. And I had to take somebody off even 25 milligrams the other day. She just did not, she was a teenager. She did not tolerate it at all. As far as, don't forget the aspirin, folks, for clot reduction. And another option other than the iodine or the mouthwashes they're talking about is Budesonide throat spray. They used to have a nasal spray, but you can use a nasal applicator or the LSF formula for that.
Yes, and I think that's actually coming on a slide too. I prefer, in general, I often go to herbs first. And so the Biocidin is great, especially, and there's a new one, right, that has a couple of probiotics in it. And so that's a great one too. But Biocidin in your neti pot or in the nebulizer. And personally, like if I was in the house with someone that had COVID, that's what I'd be using, because you want to directly affect the places where the virus would be entering. So it makes sense to wash out your mouth and your nose, right? Let's use
And you
some
can,
common sense.
right. And if you are having folks with respiratory difficulties and trying to keep them out of the hospital, we've done oxygen concentrators. And I kept a 75-year-old fella from South Africa who was visiting family. And every doctor he went to, they wanted to put him in and put him on remdesivir. And we were able to keep him home on an oxygen concentrator. And he was nebulizing albuterol, and we put Biocidin in it as well. None of his family members were affected by the virus. And we checked in on him 7 days later. He was jumping around on the couch, healthy as all get out. And this is a guy with COPD. So he had underlying problems, but we saved this man's life. Had he gone in the hospital, I'm convinced they would have killed him in there. So whatever you can do, whether it's getting home health agencies to provide patients with oxygen generators to keep their SATs up, because his was dipping down below 88%. And that you have to pull every string, do everything you can to keep people at home and out of the hospitals. All bets are off. The two patients I lost were both men my age, were friends of mine, one in Georgia, one in Florida. They came late to the game because they weren't really active patients. One of them got one dose of ivermectin before he had to go in the hospital. The second never got any. And as soon as they hit the hospital, everything I put them on was discontinued. And after 6 weeks, both of these gentlemen passed away. They were on the vent for 2.5 weeks. Both had chest tubes and things like that. One went into renal failure, I'm sure, after his second round of remdesivir blew out his kidneys. So to me, we are working, and I know Kate is doing the same thing. We're working super extra hard, working sometimes 7 days a week to keep people on ivermectin and on the nutraceuticals to keep them out of the hospitals, because all bets are off. Families can't even force the hospitals now to refuse remdesivir and provide ivermectin. They just won't do it. And it's so unfortunate.
And even things like vitamin C. I actually had a friend stop by this morning, a nurse practitioner who works up the road, and she was saying if a family member comes in and demands vitamin C, then legally they're supposed to be giving it in the hospital. But I'm not seeing them get even patients getting that. Now, knock on wood, we haven't had any patients had to go to the hospital yet at our practice. But in school, they do teach you, like everybody in medical school, PA school learns, if you can do anything to keep somebody off the ventilator, that's what you do, right? Because once you get on a ventilator, the chances of getting off of it are so slim.
Yeah.
So, and the damage that's done.
Yeah, 83% mortality rate on vented patients from COVID entering diagnosis. And if they do IV vitamin C, they're using minuscule doses. I mean, it's just to appease the family. They're not even therapeutic. And they use high dose vitamin C IV in the burn units. So it's not unknown to them.
Yeah, it's very frustrating, but we're doing everything we can here. So I would like you to go watch this bottom left video. I can actually post this in the comments at the end in the chat. This is like a 2.5-hour video with Dr. Pierre Corey, and he addresses so much of what we've gotten into, but he goes into more detail. I just wanted to point out that we know how ivermectin works. There's over 60 studies in peer-reviewed journals on ivermectin. Now, if you're talking about journals in the West, US, Europe, that's a different conversation, but we need to look at all the journals, especially the journals in the East, and especially in places like India, which we're going to talk about. So,
right. Ivermectin is a super, super safe drug used for over 40 years, especially in the tropics, to treat onchocerciasis, which is the river blindness, and also lymphatic filariasis, which is elephantitis. Millions of prescriptions have been given out, and there's maybe one death associated per year with ivermectin use, way less than even Tylenol. Deaths due to Tylenols. Tylenol is more fatal drug than ivermectin, and yet it's got really bad press in mainstream media.
So I think that's a good segue to talk about Tylenol. So yes, when we have a virus, we should avoid Tylenol because it directly depletes our glutathione, right? And if you haven't heard of glutathione, it's really kind of the lesser known antioxidant in the body and super important. I have been ordering the cases of the Apex trisomal glutathione, and I'm not saying that brand is necessarily better, but I've certainly seen better results with that trisomal glutathione. It has phosphatidylcholine, which is excellent for people with long or chronic COVID. But yeah, don't take Tylenol if you get sick. You know, if you have to take something for the headache, take aspirin. And then secondarily, we can use Advil if we have to, but I would say skip the Tylenol for sure. And then I think we talked about a lot of this already. So I'm actually going to go forward so we don't run out of time. We do IV ozone here, as I know a lot of you already know. Here's some information on IV ozone. I will also put this link in the chat. This talks a little bit more about its efficacy with Ebola. You know, IV ozone is very safe. The only place you can't put ozone in the body is the lungs. However, you can inject it into joints and it does help reduce damage. Helps with healing, helps with infections. So, and I will send out this article so everybody can see this. Let's see. Okay, and then Dr. Saleeby, do you want to talk a little bit about long or chronic COVID?
Yeah, so this comes in many, many different names. Long haulers, which I don't like, most doctors don't really like it. Long COVID, post-COVID syndrome. It sounds almost like they're talking about the post-treatment failure Lyme kind of thing. But and then now the new nomenclature is post-acute sequela of COVID, or PASC, which I like the least. Actually, I like the post-COVID syndrome the most. But anyway, we're seeing a lot of this. It's affecting more women than men. It's affecting folks that are coming out of hospital. So we're seeing up to 75% of these chronic COVID situations in hospitalized patients, and somewhere around 30% in outpatient COVID patients that go on to progress to long COVID.
Sorry.
That's okay. Part of it is response to immune escape, persistent immune response syndromes like CIRS, chronic inflammatory response syndrome, or MCAS, which is mast cell activation syndrome, which we treat as part of the wing of the protocol they use for this, macrophage activation syndrome. And a lot of times we would expect some of these biomarkers of inflammation like CRP, NF-kappa B, all these, we'll mention them later in another slide. We would expect them to be elevated. And lo and behold, we're not finding that. I did a long COVID patient yesterday and reviewed his laboratory. None of his inflammatory markers were elevated, but he was very symptomatic. I think that's just a repeat of everything I've said. You got to get people, you got to get people on COVID, with COVID on ivermectin rapidly for many, many reasons. It can turn people around in 1 or 2 days. The long COVID, even if they're a year out and have long COVID, you can use ivermectin more aggressively. I use it because it's a long-acting drug. I've been able to dose it every other day. I've dosed it every day and at really higher doses for folks with significant symptoms, and we do it until symptoms resolve. You can also use nitroxoxide, which is Alenia. It's harder to get, more expensive, but I use, again, some other agents we'll talk about in a minute. I'm not going to read all these, but there's up to 150 different symptoms of long COVID. They keep adding more each day. It's surprising. A lot of neuropsychiatric stuff, visual disturbance, GI, obviously tachycardia, dysrhythmias, heart issues. CHF is a big problem with women. Females, I think, die in the hospital mostly due to congestive heart failure, how it's affected them that way. You can also see increase in some other viral titers, EBV. I had HHV6 titers increase on a patient. And then now we're discovering more cases of Lyme disease because it activates Lyme. So people who historically were maybe asymptomatic with it, maybe have had it since they were 5 years old, didn't know it. Now it's coming to the surface. And we're seeing things like IL-6, CRP, fibrinogen, VEGF being kind of within normal ranges, which is unusual for us. We're usually treating Lyme patients, we're usually seeing them pretty high. And then there's something called CD16 plus, which I'm looking for a lab to be able to do, is a long-term inflammatory marker for long COVID. And as Kate mentioned earlier, checking T cell testing when the SARS-CoV-2 IgM, IgGs, or spike protein antibodies are coming back negative is a great thing. And then POTS, everyone knows, what POTS is with blood pressure and tachycardia. We're seeing some of that also with long COVID. Again, you want me to tackle this one, Kate? Ivermectin. So ivermectin.
And I wanted to bring everybody's attention to the iRecover. So the FLCCC, which again is 3cs.net, you can go there and also see the long COVID treatment.
Yeah, they've got IMath, which is the inpatient, which nobody's really adopting. And then the iRecover, and there's like 3 or 4 pages. So don't forget to toggle through and look at all the different pages. There's a lot of information. It's all got a lot of references. But the mainstay of therapy is ivermectin. Dosing depends really individualized based on their symptoms, weight-based, and then the length. You can do it 5 days to 10. I've got some patients on long COVID who are on 20 consecutive days of ivermectin, in addition to some very aggressive things like leukotriene inhibitors, like Singulair, fluvoxamine. Steroids we do judiciously. I'm not a big corticosteroid fan, but there's a prednisone taper that's on there that you can use. And I've had patients have a very immediate response to that. A young lady with COVID headache responded extremely well. But once she's off for COVID, now her pain scale's down to 2/10. It was 7 to 8/10. Vitamin D, we have to get aggressive and check serum levels. You want higher serum levels, maybe 70 to 80 nanograms per ml. And low dose naltrexone, I'm a big prescriber of it for many, many reasons. LDN in the acute phase may not be so great because it takes a while for that to get in your system, but for long haulers, it's good. I start them on anywhere between 0.5 and 1 milligram, usually in the mornings, and then, or sometimes BID if they're having issues with pain twice a day, and then rapidly accelerate it. Like every 2 weeks, I'll bump the dose up until I get to about 4.5 milligrams on a daily dose. And if they tolerate the mornings, then I shift it to once a day dosing at nighttime. But if there's pain and myalgias, I'll keep it at a BID dose, twice a day dose. And then we have to treat for MCAS, for the mast cell activation, using a series of antihistamines and leukotriene inhibitors to suppress this, because that can make people miserable. And then Kate, you want to talk about the HPA axis and adrenals?
Yeah. I mean, to me, this just gets into the crux of what we do on a daily basis, even before COVID, right? So we're seeing patients with elevated cortisol, although lately it's all been low cortisol levels. And some people have a reverse curve where they have very low cortisol in the morning and elevated at night. And obviously there's also probably something going on with their melatonin, so that their melatonin is not peaking at night naturally. So because cortisol and melatonin directly oppose each other. So when your melatonin goes up, we want your cortisol to go down. So, and I'm also checking pregnenolone, DHEA, cortisol in everybody. I'm seeing a lot more patients that need to bump up their thyroid medication after COVID. And I think just to comment about the white blood cells and the Epstein-Barr, it does seem like the immune system is so distracted that then anything else that could have caused an issue is going to cause an issue. And so sometimes you have to dig. Like I had somebody the other day and it's a parvovirus, it's not an Epstein-Barr and it's not a cytomegalo and it wasn't anything else. So it's interesting, if you're playing detective and doing a full workup, then you're going to find these things anyway. But definitely after COVID, I think people sometimes don't realize that the symptoms are due to the fact that they did have COVID. However, these underlying long chronic infections are part of the problem. So it's a time when we need to step back and get the whole picture and then kind of zoom back in and adjust things, if that makes sense. But it's a lot, and it's a lot to do on your own. And I wish there were more providers checking all the hormones, especially cortisol and pregnenolone, because I think it's really important for recovery. So. Okay, and then this is kind of everything that Dr. Saleeby's been using for long COVID.
Yeah, I can give you some doses. Let me whip out my paper because I think Kate put this up before into the slide deck before I was kind of finished. But again, high dose vitamin D therapy is very important, and you got to watch your folks' serum levels. 125 milligrams is equivalent to 5,000 IU, and that's the base. 5,000, we go up to sometimes 20,000 for a bit and follow. Vitamin C, you're talking about 1,000 to 3,000 or even higher. Liposomal vitamin C is even better. Vitamin A, 8,000 IU is equivalent to 2,400 micrograms of vitamin A per day. Zinc was covered nicely by Kate. Quercetin as well. Lutein is another agent that's carotenoids found in foods and most eye formulas for macular degeneration. That can be helpful at 20 milligrams plus per day. EGCG, somebody asked a question about that being used in lieu of quercetin if not tolerated. And yes, it is an -4, so you can use EGCG, epigalactocathecin gallate. It is found in tea, but it's an extract from tea. 100 to 600 milligrams daily, and use that with your zinc to push it in. Echinacea, you can use it, but not more than 3 weeks consecutively, and then you need to back out. Singulair, which is a leukotriene inhibitor, helps with MCAS. Usually it's 10 milligrams a day for 15 days. You can go longer. If it's a pediatric, you can use a lower dose, 4 or 5 milligrams. Ketotifen is an antihistamine, 1 milligram a day, again for MCAS. N-acetylcysteine is great. I love using it in hollow organ infections. It's great for the lungs. It helps make glutathione in the liver. 600 milligrams TID for those with issues with lungs and bronchitis and COVID pneumonia. And then, of course, I mentioned LDN before, and fluvoxamine, Luvox. I find that you have to go gently with that because it is not often tolerated too well. Kate seems to have better luck with it than I do, so I have to be kind of careful. Black cumin seed extract is an anti-inflammatory. You can pair that one up with curcumin, and of course, curcumin turmeric is a great anti-inflammatory. And early on, they discovered, even almost 10 years ago, they discovered when they were looking for something for Zika and chikungunya virus during the Brazil Olympic Games to help prevent the spread of that. They looked at curcumin because apparently on those type of viruses, they also have the S spike protein, and those will not attach to human cells as readily if you've got curcumin on board. So curcumin helps reduce the spread of the virus from person to person and spread of the virus in yourself too, as it's trying to replicate. I've added andrographis, which is an adaptogen herb. It is actually on the formulary of the government of Thailand as an official agent to use in treating COVID patients. This is acute COVID. So I've used andrographis anywhere from 200 to 1,000 milligrams a day. Dr. Buhner writes about andrographis in his Lyme book, Healing Lyme. I've used it a good bit in my Lyme patients. You have adaptogenic properties as well as antimicrobial properties with that agent. Now, that's not on the FLCCC website. And also Artemisia or wormwood, sweet wormwood can be used in addition to or as a replacement for ivermectin if it can't be had. And then the last thing, and it didn't make the chart, this list, is peptides. So peptides can be used to heal tissues that have been damaged, like lung tissue. And I'm using peptides as a second round agent. Things like BPC 157 and TB4 frag predominantly, but also KPV if there's GI involvement in some of my long haulers, and they seem to work really well, but you got to dose them aggressively. Not that what comes on the package, but like double, triple the dose, at least in the first few days.
Yeah, and actually someone had mentioned the peptides, and that's really a exciting new area of functional medicine, I think. So I want to see if we can get through anything else we didn't answer in the chat. And let's see, what else did we had? This was, we did have one question there about vaccine in a 12 to 15-year-old population. And then how efficacious is the vaccine? What are we seeing? I don't know how efficacious it was before Delta, but I know that starting in September, I started seeing quite a few people getting COVID that were vaccinated. So I'm not, and it's still experimental. So I'm not telling people to go out and get it in a general recommendation. Again, a lot of this is hard to talk about generally because we really need to have these individualized visits with patients so we know what's going on with them. But I do think if you are working for someone that's requiring the vaccine, we wanted to talk about that for a moment. Just, the medical exemption, there were attorneys that spoke at the conference about what to do about medical exemption. And it's a tricky area, but in general, blood clotting is still kind of counting as a medical exemption. Especially for people like we have a patient that just is working from home and doesn't have much risk of being exposed. So they can't really say, well, you have a risk of clotting from COVID because she's actually working from home. And I think it is helpful to have an attorney if you think you're going to lose your job because of the vaccine. And there's a list of attorneys that will help. And the other comment about that was the blog post, which Dr. Saleeby put up on his blog. So I'm going to share that in the chat and just share a couple articles in the chat with links. Someone else actually asked about, I think, peer-reviewed data. I think that person was asking about supplements, peer-reviewed data about nutraceuticals and vitamins, but I can put a couple of links that we have used. There's, regarding vitamin D and zinc and vitamin C, there's way too many studies or links to list them all. But if you need some links just for your own reading, just let us know.
And the thing is, we can't always depend on randomized controlled trials. They just don't exist in the world of nutraceuticals as much as we would like. And even the ones that are coming out, there's a large number of retractions on a lot of the data in the high powerful journals like Lancet, JAMA, New England Journal. So, you have to look at clinical observation. Sometimes we as practitioners, we can't discount that. And, everyone's so seeking evidence-based medicine. Well, I have evidence. I mean, in my clinical practice, I observe things. I'm not blind. So that should count for something. And if you're an academic, maybe you're put off by that statement. But I'm going to practice to do what's best for my patients, whether there's a study behind it or not. And there's plenty of studies that don't do our patients any good. And you'll see that coming out with remdesivir and some of these other things that have been FDA approved or recommended by the CDC and NIH. And they're absolutely horrible therapies. There's some British studies that show that vaccines amongst children is dangerous and that the efficacy and when you compare vaccinated to unvaccinated, there's a higher death toll in folks among fully vaccinated compared to unvaccinated folks. And this is from some British data. There's the Israeli studies coming out showing higher rates of hospitalizations with infection after even third doses fully vaccinated with boosters, which is now going to become a very big bad problem. And what's not being reported is the sequela from the vaccine, which is going to be another wave of people hitting our doors with all kinds of chronic illness. So we're going to have to prepare ourselves to meet that kind of second and third wave, not COVID necessarily, but this post-COVID stuff. And of course, now there's a slide up here which talks about Merck's newest drug for COVID, molnupiravir, which is a 5-day course, and it costs over $700 for that 5-day course. Is it effective? Well, some of the studies, I think Pierre talked about some of the studies that showed something like 47% reduction in death and hospitalization. Well, look at ivermectin, 88%. This is a no-brainer. I mean, you prescribe ivermectin, for crying out loud. It's dirt cheap, and it has twice the effectiveness. The whole thing about repurposing drugs, big pharma doesn't really like that so much because it really it affects their bottom line, their profits. So they're looking for new agents where they can monetize those a lot better and potentially worth billions of dollars, if not trillions, in the long term.
I wanted to get a little bit of clarity. Krista, I feel like you tried to ask this a couple of times. Can you tell me what you mean by, do you know where SARS-CoV-2 has been isolated? What do you mean by where? Like parts of the body, parts of the world, laboratories? Do you mean, can we tell if patients do have it? Is that?
Well, maybe I can chime in here while she's typing her question, but in China, they actually swab certain parts of the body that are higher yield. So while we're swabbing noses over here, in China, they're swabbing the rectum or people's behinds because there's higher concentrations of this virus coming out. So there's a higher yield. So maybe a lot of our false negatives on our swab test is poor swabbing, or maybe we're swabbing the wrong orifice. But I just want to throw that out there, that the Chinese may have one up on us.
I also felt like, especially in the beginning of the pandemic, that there was a big user error with how the swab was done. When I do swabs, they're pretty intense. It's not like a quick little pleasant thing, so and we're using the PCR sendouts if our rapids are negative, but our rapids, anybody that's had symptoms lately, our rapids have been positive. So in the last 3 months, all those symptom people, the rapids have been positive.
So I'm not going to recommend molnupiravir for any of my patients, I don't think. Not just because of cost, but because there's a better drug out there that has a 40-year track record of safety, and it seems to be pretty effective. And there are something like 36 randomized controlled trials showing that ivermectin is effective against COVID. It's not like what you're hearing in the mainstream media. But I don't think we should end this, Kate, until we should talk about Uttar Pradesh. I think is that in your final slide?
Let's see, do we have the final slide? Yes, here we go.
Yeah. So one of the most populated states in India, it's the northern part of the nation of India, has a state called Uttar Pradesh, and they have essentially eradicated COVID. There are very, very few cases that are popping up, and the death rate, the hospitals are empty, and there's nobody in the ICUs with COVID or post-COVID issues. And this is a huge state. It's equivalent to about 65% of the US population. Okay. So a lot of people, 204 million people live in that area. And essentially you can't find COVID anywhere. And it's not because they vaccinated. They actually have a fairly low vaccination program in that particular state in India. It's different in other parts of India. But what they did is they had a program where they were contact tracing all the folks that tested positive, and immediately those people got a kit which contained ivermectin and the nutraceutical bundles, and that's how they broke the pandemic in that region of India. And there are other countries that have done that as well in South America, countries like Guatemala and what we would consider third world countries. I mean, I think probably in Uttar Pradesh, a lot of the folks that live there don't have running water or electricity. And here we are, an industrialized nation, and we're still having issues. We also, it was reported on Dr. Pierre Corey's Twitter account that because he has treated some members of Congress, he went before a special subcommittee in Congress, I think in December of 2020, to urge Congress and our legislators to free up and allow ivermectin to be prescribed in the hospitals. And he says that he's treated about 200 US Congress people with ivermectin, and you're not hearing that in the media. And I don't know why there's so much pushback and why we can't do this without being hampered for our patients.
So now we've got a little bit over time. So if you have to hop off, I understand. I'm going to see if I can answer a couple more of the questions that are in the chat. Carrie had mentioned, are you able to comment on whether therapeutic methods are better than vaccination at this point? So something I just wanted to mention was that I have seen that when I have patients under our care and their inflammation is lower, like say I met them a year ago, and then their vitamin D and their zinc and their B vitamins and everything else is at a much healthier level. When they do contract the virus, they do much better than the person that I just met who has very low levels of vitamin D and zinc. So that's one thing I would comment. It's very difficult at this time to do like a vaccinated versus unvaccinated, like big study. I mean, what we're commenting on this entire talk is just our clinical experience and what we've seen in the last 19 months. So I'm certainly, again, still seeing people that were vaccinated that are getting it. And is it also related to inflammation and stress? Yes. Are people being exposed? Yes. So we could have a whole conversation about the masks too, but I don't know that that's worth it right now. But the bottom line is that no, we're not wearing the masks correctly and we're touching them. And I watched my second grader and fourth grader march into school as they're like, shoving their hand under it and all sorts. I mean, it's just not being worn correctly. So it's obviously not working. So. Yay, Amber's saying she did great. She did. Let's see. And then Carla had a question about famotidine or nebulized food grade peroxide. So yeah, I wouldn't do 3% peroxide. I would definitely do way lower. I prefer the Budesonide, but some people, if they have it on hand, are willing to try it. Again, it's a matter of we're trying something as opposed to doing nothing. And we do want to attack the nose and the posterior pharynx and the parts of the body where the virus is living. We want to wash those out. If you think you're exposed, like if you're living in close proximity to someone that has it. Famotidine, I mean, I personally haven't used it too much for.
I'm using.
Yeah, are you using it, Dr. Saleeby?
Yeah, Pepsid, over-the-counter Pepsid, 20 milligrams once a day or twice a day, is a H2 blocker, so it's very helpful in MCAS to suppress the mast cell activation. I use that in conjunction with Singulair and ketotifen or other antihistamines. So it was prescribed in the acute setting. I think President Trump, when he got COVID, he was prescribed famotidine along with some other regimens, but I don't typically use it right up front. But if somebody has a little reflux because they've got some GI issues, well, heck, that's the one to pick. You don't want to pick a proton pump inhibitor for sure. So throw some Pepsid at them. Wouldn't hurt.
Yeah, I already have quite a few people that are taking an H1, H2 blocker, so we don't change that because they got COVID. I think that's the key, is like what was going on before is going to get worse, right? If you had mast cell before COVID, you want to manage that during COVID.
Right.
Or eosinophilic esophagitis, which quite a few of our patients have.
Right.
And then Karen mentioned Dr. McCullough does have a YouTube video. Karen's a nurse practitioner down the street, and she's saying it's 0.1, but I've seen people patients use 1% as well of peroxide. Again, not necessarily something we're recommending, but I do think the Budesonide would be worth trying.
Yeah, I'm not a big fan of nebulized peroxide. I know Dr. Brownstein is. There's a YouTube video out there where he does it, heavy, heavy use of it, recommends it, and uses pretty high concentrations. I've just never been a big fan. So I do the iodine I'm okay with, and the Budesonide I think is an excellent choice. Can't do any damage with that really. And you have different forms. You can nebulize it. You can use it in neti potties. You can also you consume it under your tongue, orally, versus more systemic use.
Yeah, and I think some of this is, I don't know how Dr. Saleeby feels about this, but I took a muscle testing class. Is Dr. Iris still on here? I took a muscle testing class a couple of years ago because the truth is that sometimes we do have too many options, right? And we need to focus a plan, whether it's Lyme disease, chronic fatigue, Epstein-Barr, whatever's going on. COVID is not different. We often have too many options. And so this is where I also use muscle testing to just say, okay, is this person going to do well with iodine, or is this person not going to do well with iodine? It takes a lot of practice. It's not something that you just start doing and right away you can muscle test perfectly. But as I get more comfortable with it, and also just using our clinical judgment, sometimes if you've been doing medicine for a while, you look at someone and they tell you they feel fine, but they just look really sick. And that's something that you get from practice. So I think, again, this presentation is intended so that there's a lot we can do, but I don't want people to leave the presentation and try all these things. I want you to call one of us. So I hope that was obvious.
I think it's kind of hard to navigate if you're just going to stick with the 4 basic nutraceuticals for prevention. I think you can't go wrong with zinc, quercetin, vitamin D, and vitamin C. But if you're going to navigate post-exposure or early COVID, you really need to hook up with a provider who's knowledgeable and can help you navigate and use what's best for you under your personalized way of getting therapy. Trying to just throw different things in the mix probably won't serve you very well.
Yeah, awesome. Okay, well, I think we'll end there. If anybody has additional questions, Dr. Saleeby, do you have a general email if they can get in touch with you, or I think you posted your website up above, right?
I did. So we had to have when we joined the FLCCC Alliance, we were slammed. Our phone system blew up, our email blew up. So we had to create a landing page. It's saleeby.net/COVID, where you can get quicker access via email. We even set up a separate email. It's COVID, COVID.c, Carolina Holistic Medicine, CHM, the abbreviations for our clinic, @gmail.com. So that's the best way if anyone wants to reach me. And it's manned by a staff of people we triage. So we actually are able to help the folks with acute onset symptoms. And then second in line would be post-exposure. And then there are folks that just want ivermectin on hand for prophylaxis. But we triage them to get to the acute sick first. And I can post that here. I'll post that that's a particular email address.
You said COVID@CHM?
COVID.CHM for Carolina Holistic Medicine @gmail.com. I'm typing it in now. And then it's saleeby.net/COVID is where you can go and quickly fill out all the forms. So if you're not a patient actively, you would go through that process and we can get you taken care of. We have 5 advanced providers now working for us. So we've got enough staff to handle inquiries within probably 24 or 48 hours.
Okay, I'm going to stop the recording here, and I've got to hop off, but I really appreciate everybody coming today and asking your questions. And if there's things that we didn't get to, again, I think the takeaway here is, again, it needs to be individualized, but fear-based medicine is not good. So going with some education, some information and empowerment, and I'm hoping that's how you're walking away today. Get some rest, do your meditation, get a walk in today, and I hope to see you all soon.